I'd like to share my thoughts on where we're at with anti-aging medicine. Can we really meaningfully extend life with interventions and drug therapy? What's available now? What's the FDA stance on it? So there's many approaches to anti-aging medicine. I go to anti-aging medicine conferences. 20 years ago, actually 2004, I was a board certified in anti-aging medicine by the American Academy of Anti-Aging Medicine. I was a board examiner for them. And back then, it was mostly about wellness, a little bit of hormone replacement therapy, some growth hormone stuff. And fast forward 20 years later, our knowledge of age has improved. Our way we measure age has changed dramatically. And the tools we have available are widened, and research is being done on drugs that may meaningfully extend life more than just wellness stuff alone. So I think this in a few tiers. So tier one is just general healthcare and wellness. So like if you go through traditional healthcare, you do extend your life. For example, if you have high blood pressure and you don't treat it, you're going to die sooner. If you have diabetes and you don't manage it, you're going to die sooner. So there's conditions that healthcare right now extends life. A lot of people badmouth the American healthcare system. We have an unhealthy society in terms of obesity and some other things. But we have a world-class healthcare system. Now it's very expensive, trillions of dollars. And we are living longer than we were, say, 100 years ago. But that rate of length is slowing down. In fact, it's reversed a little bit in the last few years for a variety of reasons. And back, say, a few hundred years ago, there's a lot of reasons to die young: infections and war and trauma. And then other people live very long. We look at the Signers' Declaration of Independence. Most of them live past 80. But in general, lifespan back then was in the 40s and 50s. Now we're, much longer in the late 70s. How do we get our age ends extend further? So wellness is number one. You need to do your regular healthcare. And then there's things like there's the Finnish study on saunas that shows decreased cardiovascular mortality. There's, eating properly. There's a lot of intervention you can do with alternative medicine doctors to get yourself healthy, make sure you have good amount of minerals in your body and vitamins, proper vitamins in your body. So that's something that I'm not going to talk about. It's all very important. Exercise, lifestyle, that's very, very important. I do it myself, but I'm not going to talk about it in this discussion. Then the next thing is regenerative medicine. And I'm just going to briefly go over regenerative medicine, how we're approaching it. So if tissues are degenerated, can we regenerate them? Well, one would be stem cell therapy for joints. So for example, if you have knee arthritis and of normal weight and it has some impairment on your, say, exercise, you've shortened your life about 1.8 years. And if you're obese and you have arthritis in a single joint, it's about 3.5 years. So restoring that with regenerative medicine, which would be stem cell therapy, or PRP, which works to some degree, platelet-rich plasma, you can get that extension. Something I'm very excited about is treating apnea. I've written a book on apnea. You can get our books. I've written several books on regenerative medicine and even on sleep apnea. But go to our Lower Medical Books and Google that. You'll find our books. But sleep apnea shortens our life. So there was a study done in Wisconsin in 1988, and the National Institutes of Health sponsored it. We didn't know if sleep apnea should be treated back then. So we did a study where we followed people for 20 years, and they measured their sleep apnea score. They gave mild, moderate, severe. And 20 years later, they went back to look at the death rates. And people with severe sleep apnea were 3 times more likely to be dead than people with no apnea when they matched for other factors such as their age, smoking status, obesity, et cetera. In fact, people that had sleep apnea lived about 6.4 years less. And studies are showing that treating sleep apnea probably adds 6.4 years if you have severe sleep apnea. So that would be a regenerative therapy. We do what's called a night-lase procedure or apnea-lase procedure, where we regenerate the airway so your sleep apnea gets clinically insignificant. Hormone replacement therapy, I think of that as a regenerative medicine because your organs degenerated. If you went through menopause, your ovaries are no longer functioning and your lifespan shortens. And we know from numerous studies that hormone replacement does reduce all-cause mortality, all causes of death, reduces cardiovascular disease, breast cancer, particularly with testosterone in women, and probably adds about 3 years onto your life if somebody goes on hormone replacement long-term. For men, largest study ever done was in the VA, about 83,000 men followed for 6 years, average age in the 60s. And they found men with low testosterone that did not treat the low testosterone were twice as likely to be dead in the next 6 years than those who treated their low testosterone. Testosterone replacement therapy extends life meaningfully in some of these clinical studies. Now, Testosterone is not FDA approved for life extension. In fact, it's only FDA approved for men that have low testosterone due to a brain damage, missing a testicle, or having an extra female chromosome, but your doctor can prescribe it for you for any reason. The FDA just governs what manufacturers can say. And testosterone was FDA approved for women for breast cancer. It's very good for breast cancer, for metastatic breast cancer back in the 50s, before it was FDA approved for men. There's no form of testosterone available right now for women other than compounded. So we get a compounded pellet for women. And so we use testosterone, estrogen in women, along with progesterone and testosterone in men. That's regenerative therapy. Circulation problems, we're really passionate about advanced venous disease. Now, there's varicose veins that aren't going to kill you, but there's venous insufficiency that's advanced, where people get sores on their legs and swollen, heavy legs, brawny legs, ulcers on their legs, and this meaningfully shortens your life. We have a treatment that reverses that. I was instrumental in developing it back in 2006, and we reroute the blood to get a normal, healthy leg. Fat reduction, I can think of that as regenerative as well. So obesity is a metabolic derangement. And if we can reverse obesity, we can also extend your life. And right now with semaglutide and other drugs, we're seeing some meaningful improvement in obesity. So that's regenerative. So step one was general wellness. 2 is regenerative. 3 is don't die of anything stupid. And it sounds mean to say that, but it's not always true, but we can detect cancer pretty well. We detect cardiovascular disease pretty well before it happens, and neurocognitive decline way before it happens. So how do we handle heart disease right now? We do cholesterol, which is pretty useless. Maybe a stress test, not going to tell you anything unless you're about to have a heart attack next week. And that's it. But we can actually scan for people and identify who's going to have a heart attack 10, 20, 30 years from now. So for young people, we can do a calcium score, which is a CAT scan. It costs about $99. And that identifies people who are young that have some calcifications in their arteries, which means they have some ongoing disease. And this is really good as a screening tool. You can't use it to map out progression. We can identify people in their 30s that are likely to have a heart attack in their 50s. And then we can do what's called a CIMT, carotid intima media thickness test, which is a study of the arteries, the neck arteries. It's a good window into all of our arteries, and give you a cardiovascular age. So if you're 50 and your arteries look like they're 60, we know you're going to have a heart attack sooner than your peers. And if you're 50 and your arteries look like they're 30, probably not going to have a heart attack. So you're in good shape. Keep doing what you're doing. And this is something we could use to detect cardiovascular disease non-invasively way before it happens. Very inexpensive. Legitimate tests. They've been around for years. They're not covered by insurance, so doctors don't order them. And these are $100 to $300 tests. I mean, we're doing all these blood work for expensive money, stress tests, angiograms, and we can just do a $300 ultrasound test to screen for disease. Now, if it's there, you might need to do more stuff, but if it's not there, you're good. Cancer. So we have our traditional cancer screening, mammograms and pap smears and CAT scans and smokers of the chest, colonoscopies and others, skin checks. But there's 2 additional ways to detect cancer that increases the probability of picking up cancer before it's a problem. Now, cancer, once it becomes the size of a grapefruit, it's very likely to kill you. And if you pick it up the size of a peanut, probably can survive it. You can resect it, take it out, particularly if it's not spread. Well, if you do the regular screening test that's covered by insurance, it's mandated that insurance companies covered under the Affordable Health Care Act. Prior to 2010, it wasn't required that insurance companies pay for cancer screening, but they do now. You're only going to pick up about 1 out of 4 cancers before they're clinically meaningful, which means 3 out of 4 are going to be picked up when it's maybe too late. So what can we do? Well, full body MRI. There was full body CAT scans. There's some problems with them. They picked up too many incidental things. Full body MRIs are much more accurate. And you can't just go to the hospital. You can't just go to a hospital and get a full body MRI. They're going to actually do organ specific MRIs. It would take hours, cost, 30, 40,000. But there's clinics throughout the country that do full body MRIs with a different protocol where they're trying to look for things that are about 8 millimeter in size, which is small enough that they can run through the body pretty quick in an hour or so. Small enough slices that they could pick up stuff that's clinically meaningful, but not yet serious. And things like pancreatic cancer, sarcomas, ovarian cancers, even vascular lesions in the brain that could kill you could be picked up with a full body MRI. Costing that's $2,000 to $3,000 typically. And I've done 3 in the last 5 years, 3 in the last 7 years of my life. I think I'll do it every couple of years to look for cancer. There's something called a liquid biopsy. So liquid biopsy originally was where we identify somebody had a certain type of cancer, and we'd get the DNA of that cancer, and then we treat the person. Let's say it was ovarian cancer or something. And then we do blood tests to see if there's any remnants of that cancer still floating around, so we know if they're in remission or not. Over time, they got enough of these signatures, enough of these thumbprints of cancers, where now you can just get a liquid biopsy, we draw your blood. The test is called Grail. It's Galleria is the company, and they make a test called Grail. So we're from $650. I've heard Henry Ford Hospital locally here is about $650. We get the kits for about $950. It's reasonably cost effective. It's not that good yet. but it's the best thing there is for liquid biopsy. It picks up several different tumor types that could be very early stage or late stage. So you combine your regular screening with MRI and liquid biopsy, and it's negative. You probably don't have cancer with more than 99% certainty versus just doing your regular screening. Then neurocognitive decline. So my mother died of Alzheimer's, and Alzheimer's does kill people. She couldn't figure out how to eat or drink. It's just a horrible way to go. And she went down pretty fast, 2 years. That was painful to watch. And by the time we knew she had it, there was no intervention. However, if we picked it up earlier, we might have been able to do something. The brain is plastic. It can be repaired. We know that there's ways to intervene on early Alzheimer's. Late Alzheimer's, not so good. And you can do an MRI, what they call neuroquantitative imaging. So what happens when the brain ages is it shrinks and the water in the brain gets bigger. Okay, so you have liquid in your brain called cerebrospinal fluid, and you have ventricles and spaces that hold this liquid. And then you have white and gray matter, that's your brain part. Well, as your brain gets older and degenerates, it gets smaller and water takes up the space. Well, you can look at your age and your peers and say, where are you at relative to your peers? And if you're at the 99th percentile, that's good. It means you're not anywhere close to getting Alzheimer's. You probably won't get it at all. And if you're bottom 20 or 30 percentile, you're probably the one that's going to get Alzheimer's unless you do some intervention. Okay. I'm not going to get into all the interventions. I wrote a little bit about it in one of my books. For example, if you have apnea and Alzheimer's, you better treat the apnea. Apnea does accelerate Alzheimer's significantly. And there's other things that can be done to create the brain to regrow that have been done in various studies. So don't die anything stupid, which would be neurocognitive decline, cancer, or heart disease. And even if you do all these testing, you still might die of those things, but your chances go way down, or you delay it for a significant period of time. Those are things you can do outside of your health insurance. Health insurance was really designed to treat disease, not prevent it. And until the Affordable Health Care Act, there was no covering preventative care. It was not mandated. It might have happened. It wasn't mandated. Now we have a few things covered, but if you really want to do true preventive care, you're going to have to pay for it. And that's just the way it is. So would you love more, your life or your money? If you love your money better, keep it. If you love your life better, go ahead and spend some money on an MRI, about 2,000 or 3,000, a liquid biopsy, about 1,000 or so. And the brain MRI, I've had it done myself in a comprehensive with other testing. I'm not sure how much it costs. I would imagine 1,500 or so. And the CIMT is about $300. We do that at our clinic, the CIMT, which is the cardiac aging. It actually gives you an age of where your cardiovascular system's at. And if it's problematic, the CIMT, we can actually do more advanced tests of your heart itself. So those are the first three: general healthcare, wellness, regenerative medicine, don't die of anything stupid. And the fourth stage is truly working on reversing your age. Now we got to talk about how we're going to measure the age. And a lot of people have heard about telomeres. These are little strands on the end of your DNA that shorten as we age. Well, there's a lot of variabilities and things that affect that. So it's maybe not the best way to measure age, but something we were doing for years. So typically if your telomeres were shortening fast, you're coming close to the end of your life. And if they were longer than your peers, you're going to live a little longer than your peers. But it's fraught with problems. And now we're replacing it with what's called the epigenetic age, epigenetic. So genes and epigenetic. And this is a marker. It was developed initially by Dr. Horvath, I guess about a decade ago. And we can really predict when you're going to die, excepting, of course, a car crash or some unexpected thing. But our body, our genes put little methyl groups, little chemical bonds on our genes. We have this ATCG on our genes, and it puts it on the C. And it's basically a clock that tells you how old you are. Some people age, say, 1.1 year per year. And some people age 0.9 years per year. The person that ages at 0.9 years per year is likely to live to 100. And the person that ages at 1.1 years per year is likely to live to 55, 60. They're the ones that are going to have that premature heart attack. And I'm one of them. My genes are aging faster than myself. Not that much faster, but faster. And I've reversed that. So that's one thing we can measure. We can also measure physical aspects of aging, such as how do we look? Are we strong and fit? Does our skin look horrible? Does it look great? Are we walking hunched over and slow? We can measure our strength. We can measure our VO2 max, how we can extract oxygen out of the air, which is a sign of fitness, which would likely live longer if you're fit. We can measure our bone density. We can measure our organs. Is our brain older than our body? I talked about that earlier with the neuroquantitative imaging. We can measure our ejection fraction of our heart. We can measure fat around our liver. we can measure multiple things that have to do with aging. The cardiac age, I talked about the CIMP, will say how old your cardiovascular system is. Well, the wellness stuff in the general healthcare can actually impact brain age and cardiovascular age. And I know this, I've done it myself, and we do it for patients, and this has been well established. So you can definitely reverse cardiac age. There's no question about that. Drug therapy, lifestyle changes. Drug therapy is definitely part of it, a big part of it, but lifestyle changes as well. But how do we impact our other aspects of aging? Well, there's a couple other things you need to know about. Maybe you've heard about it a little bit. One is called cellular senescence. Senescence like senile, being senile, senescence. So our cells grow and constantly replace themselves. So we're born with a germline of cells. We become an embryo and turn into a little baby. And by the time we go from germ cell to baby, before that time, we're actually immortal. Those cells can grow forever. But once we get actual tissues, now those cells are mortal. They're going to die at some point. And the cells are turning over and over again. And over time, they start accumulating damage in the DNA. The damage in the DNA has to be mitigated somehow, or it would turn into like a tumor, for example. And so our body has a protective mechanism, which is called senescence. Other protective mechanisms as well, but senescence, where if the cell has damage to it, it goes into a state of senescence where it stops growing, becomes kind of like a zombie cell. I've heard that term used. Becomes a little fat, gets these big vacuoles in it or water pockets in it. And your body's supposed to go through and clean it up, particularly at night when you're fasting. We have a process called autophagy, automatically eating yourself, where your body would normally go through and clean up your cells at night and kill off those senescent cells, and then the healthy cells will start growing again. Well, if you don't kill those if you don't kill off those unhealthy senescent cells, they put out a juice called SASP, secretory associated senescent phenotype, and tells other cells in the area, hey, we might have a problem here. I think I'm sick. You guys better stop growing, and let's just lay here and wait for our body to clear out ourselves, clear it out. Well, when you're 20 years old and an 8-hour overnight fast, that does happen. You have autophagies in peak effect. When you're 55 years old, there's not so much autophagy occurring, particularly not with an 8-hour fast, maybe a 72-hour fast, maybe a 48-hour fast, which we're generally not doing. That does stimulate autophagy. We're not typically doing that every day. So we start accumulating these senescent cells. When we accumulate them, we get organ degeneration, such as bad eyes, bad liver, bad kidneys, bad heart, bad joints, arthritis, bad skin. So what can we do for senescent cells? Well, we can kill them, we can inhibit them, or we can delay the onset of them. So all those things may occur. Well, this is being studied now. Doctors are treating patients with these drugs, but it's not mainstream yet. So the one is called a gero inhibitor, like gerontology, gero inhibitor block. So blocking cells from getting old. And the classic drug for that is rapamycin. Rapamycin is a drug that, if you're listening to this because you're interested in anti-aging, you might have heard about it. Most people have not. It's been around, unless you're, like, say, a transplant surgeon, because we use it for for liver transplants to avoid organ rejection. Just briefly, it's been around for decades. It was discovered on Easter Island Rapa. That's where it got its name from. And it's basically antifungal. Like bacteria makes this antifungal compound, and they studied it and found it also did other things, which was preventing preventing organ transplant rejection. I don't know if it was kidney or liver, but I think it was maybe kidney transplant rejection. So it's been used for that for years. It's got different names. There's different things called rapalogs, and it does work by delaying senescence. It is what we call fasting mimetic. It copies fasting. It might enhance autophagy. And for anti-aging purposes, people are usually taking in an episodic fashion. We're thinking once a week or once every 2 weeks. It does probably impair muscle building. So if you're, strengthening yourself up, don't take the rapamycin that week. If might take when you're just doing non-strength training exercises, the drug lasts a couple of days in your system. And it's something that's taken on an episodic basis by people that are doing anti-aging medicine. And again, it's not FDA approved for that. The doctor can prescribe it for you. That's perfectly legal. But that's what's like the common one. Metformin is also being used to some degree for that fashion. There's a large study right now called the TAME trial, TAME trial, looking at does metformin extend life. Probably does in certain populations, maybe not across the board. Certainly in people that are obese or pre-diabetic, it would extend their life. And certainly on diabetics, it's clear that metformin in diabetics extends their life more than non-diabetics. So it's very profound in a certain groups of patients or individuals. So rapamycin, gero inhibitor. Then there's senolytics, drugs that kill off, kill senile cells. And the classic one is dasatinib. It's a chemotherapy drug that has a very short half-life. And it's chemotherapy because, cancers are senescent cells. So that's one target for cancer is using a senolytic drug. And in anti-aging purposes, it's used on a very episodic basis, about once every 3 months, 3 days in a row, perhaps. We take a kind of a high dose of this drug just 3 times in 3 days, once a day, along with quercetin and fisetin. Those are pronounced differently by different people, but these are 2 other senolytics and pretty high dose. And then you turn it off. So it's sort of a precision kill shot to kill off senescent cells in the body. And then there is somatotropin agonists. Somatotropin, which is also known as growth hormone, kind of controversial. It came out years ago for short-statured children. And then in the 90s, there was a study by this Dr. Rudman in Wisconsin where he found that giving it to middle-aged men led to them looking and seeming younger. They appeared younger. Every measurement of youth that we had at the time, I got better. They got a little stronger, a little leaner, a little faster, a little sharper, able to move around a little bit better. And then there was not an abundant supply of somatotropin or growth hormone, and we needed it for short-statured children. Well, wealthy people were taking it for anti-aging purposes with a period to work. So the FDA did ban it for that use. They specifically banned it for the use. Now, in general, if a drug's FDA approved, your doctor can use it whatever they want to use it for. But there's exceptions. So you can use Vicodin for pain, but you can't take Vicodin, a narcotic, for a feel-good drug. So your doctor's got to prescribe it for a legitimate reason. There's a law for that specific one, but not for, say, a beta blocker. You can use it wherever you want to. Well, growth hormone was outlawed for anti-aging purposes, but there are drugs that are legal for any purpose. Growth hormone releasing hormone and growth hormone agonists. One we use is called sermorelin. That's a growth hormone releasing hormone. So that simulates taking growth hormone. At any rate, growth hormone was studied for in the 80s, 80s or 90s with Dr. Rudman. This was in 1990, I think. And then there was a study in 2019 by Dr. Fahey in California called the TRIMX study, TRIMX study, where he didn't really know about Dr. Rudman's work. I met Dr. Fahey. He wasn't aware of that, but he was studying it for a different reason. He was looking at how to cryopreserve growth hormone because it has to be refrigerated. He's a cryobiologist, so he knows how to make stuff not need to be refrigerated. And he used growth hormone to see if he could regenerate the thymus in adult men in their 50s. Thymus is an organ that sits behind your breastbone that's responsible for cellular immunity, which is really your cancer immunity, for example, versus humoral immunity, which is your IgG and IgM, the things we tested during COVID. So he gave people growth hormone in addition to metformin and DHEA to manage some of the blood sugar issues that occur with growth hormone. And he measured their epigenetic age. And what they found that after 6 months of therapy, they measured them at baseline, and they gave them 6 months of intervention. There's a certain pattern to it. It wasn't just taking growth hormone all the time. And then a year later, they measured their age, and they had gone backwards a year and a half. In other words, they went backwards 2.5 total years. They aged 1 year, and they were 1.5 years younger than when they started. And in personal communication, he's continued this to some degree. He hasn't published it yet, but he's seen this be done over and over again. And that's reversing basically cellular immunity failure through the thymus gland, regenerated thymus gland. And it's not clear how it affects the epigenetic age. Then we can look at the genes that make us age. There was a handful of factors called Yamanaka factors, but there's 3 of the genes that we know we believe are targets for drug therapy to extend aging. So mTOR, mechanistic or mammalian target of rapamycin. We talked about rapamycin. There's actually a gene named after rapamycin, the target and pathway and gene that rapamycin affects. If you turn that off, longevity increases in all clinical studies, which has not been fully done in humans. It's ongoing right now. But in every animal and plant studied, when they're given rapamycin, they live longer. What's more, it didn't matter when they started the rapamycin. If they started it, let's say you take a 2-year-old, a mouse that lives 2 years, and you started the mouse at 6 months or 18 months, both groups lived about 30% longer. So rapamycin affects mTOR. Then there's AMPK, another modifiable gene. We want this one turned on for anti-aging, and drugs that affect that are metformin and alpha-ketoglutarate. Alpha-ketoglutarate is a over-the-counter supplement, and there was a study done with alpha-ketoglutarate by itself, and it did reverse the epigenetic age. Again, one study doesn't really prove anything. It's just sort of a evidence, not necessarily solid proof. And metformin also acts on that gene. And then there's Sirtuin, which stands for the silent inflammatory regulator. And that is something you want on to slow down aging. And that's affected by something called NAD. Now, NAD is a part of the Krebs cycle. So those of you who are scientists, Krebs cycle, I couldn't even explain in this meeting. Is to, I could put a poster on my wall. It's the size of a wall. But NAD declines as we age. And if we take a supplement to improve NAD, we get NAD levels that of a 30-year-old and somebody that's 60. Now, the prototype that's been used is called NMN. It's a precursor to NAD. And the FDA just recently banned that because one of the scientists who's very famous, who really popularized it, has a company that they want to make it so that they get, all the money out of it. And NMN, which has been a vitamin for the last 10 or 20 years. So NMN can't be sold anymore. I stocked up on it when I knew this was going to happen. You can still get it. Not every source has been shut down. And there's other alternatives to NMN, but that is the best one. And studies show that 300 to maybe 600 days is a proper dose. David Sinclair reported dose was about 1,000 milligrams. I think that's what you make the drug on. But that does improve or does activate Sirtuin. So let's kind of recap. We have rapamycin, that is a GERO inhibitor and acts on the mTOR gene pathway. We have metformin and alpha-ketoglutarate. That metformin is probably good in certain subgroups of people. Alpha-ketoglutarate, probably anybody can take. Maybe talk to your doctor about when to take it. Your doctor might not be knowledgeable in it. I think it does inhibit senolytic activity. So we have a pathway where we stop it when people are taking their senolytic drugs. We have senolytic drugs, dasatin, quercetin, and fisetin. And we have somatotropin releasing hormones to affect the aging clock. Now, I'll tell you my story briefly. Is I've been really focusing on longevity since about 2017. I always tried to take care of myself. My dad died young. He had heart disease. He had a heart attack and a bypass surgery when I was 16 years old. He's in his 40s. He had a stroke in his 40s. Then he succumbed to congestive heart failure. My mom died of Alzheimer's disease, but not young. She was in her 80s. And I hear my dad's gene. I have what's called the heart attack gene. So I've always watched it, exercise, ate well, take a cholesterol drug if needed. And my age by all means looked pretty good. My cardiac age, I was able to actually reverse it 16 years, where my cardiac age is about much younger than I am, about 20 years younger than I am. My brain age, I've been able to reverse that as well. So my brain age is about 20, 30 years than I am. I did that through wellness. But my epigenetic clock was a little older than I was. It was a little bit older than I was, about 2 years, which means that even though I was taking care of myself, I was still going to probably die sooner than my peers. Maybe I would get some benefit from being very, very healthy and very fit, but my clock was aging a little faster than I would probably for the past, 60 years. So I started doing the anti-aging regimen in 21, and in 2023, I've been measuring my stuff right along. I had gone backwards this whole of 5 years from my epigenetic age. But additionally, my physical performance, my physique, my bone density is all remarkably improved. So my bone density is at 90 percentile for a young man. My strength is off the charts for a man my age. I'm 60 years old, and I can bench press 340 pounds, squat 540 pounds, which is unheard of for a 60-year-old guy weighing 180 pounds, who's not like an athlete. I just do the gym 1 hour a day, 3 days a week, weightlifting, and 4 days a week on the elliptical. And my body fat is right where it was in 2013. I use the same machine. I'm at 8% body fat, 185 pounds. But my strength went up significantly, notably after the senolytic drugs. And that's what I saw the biggest change on. There were certain things I was doing. And when I went on the senolytic drugs, my strength got better. And it got better by a notable amount. It was just stronger. And then I kept on doing this for a year or so. And then I said, I'm going to see if I can get back to my 2013 body density, because I was heavier than in terms of muscle mass. And I had gained about 3 or 4 pounds of fat and lost about 8 pounds of muscle, from getting older. I had a spinal surgery in 2015 that set me back a lot. So I went through a 1-year period of just working harder. And again, at 60 years old, typically you can't put a lot of mass on. I was able to put on about 8 pounds of muscle mass and lose the fat. And I got back down to my same weight from 2013 and the same strength, or maybe a little bit better. So I was able to bench into 300s when I was in my 40s. And I can do that not now, but I could not 5 years ago. And I'm not materially different in size. Again, only 8 pounds heavier of muscle mass. So the muscles are younger. They will function like a younger man's muscles. My bones are dense. And my genetic age has gone backwards. So these things are working in the right direction. This is not really ready for prime time yet. We have a few patients that are doing this. It is the unknown. We're looking at safety profile. These drugs are used for other conditions, and we know the safety of them. They're really well established. But this is an unknown. Are you really going to live longer? Well, we don't know what happens when somebody's genetic age goes younger. Do they live longer? Well, you'd assume they would, but there's not a long-term study proving that. And it would probably be, 30 or 40 years before we know that, because it would take a long time to wait for people to, age and die. But on animal studies, when their genetic age gets younger, they live longer. So that's what we have to go by. Right now, there's a large trial with dogs, companion dogs, using rapamycin. They appear to be younger and living longer. Human study, there's one going on right now. It's, I think, about 2 or 3 years into it, where they're giving people different doses of rapamycin and see how much longer they theoretically would live. This will take a long time to get the results from that. The senolytic studies have been done on people that have senescent conditions, such as idiopathic pulmonary fibrosis and chronic renal failure due to diabetes. And they show definitely a decreased senescent burden. And of course, doing more studies now, so you think of those organs to regenerate. And there's a lot of buzz about this, growth hormone study that was done by Dr. Fahey, and you'll see that being repeated over and over again. So to wrap up, general healthcare, don't jump to step 4 until you've done step 3. Make sure you get your blood pressure under control, cholesterol is good, do all your regular screening, you're eating healthy, your body fat is down, you're strong and exercising. These are all important things to do. Get your hemoglobin A1C down, below 5.2 or so. Next step is regenerative medicine, hormone replacement therapy where appropriate, stem cell therapy where appropriate, or PRP. If you have sleep apnea, that's a must treat. That's so common in America and so overlooked. And people just don't wear the CPAP devices very often. There's a surgery for it that's very expensive. They got some risks. So we use a night lace procedure. We guarantee the results of that. Your sleep apnea becomes clinically meaningless. Venous insufficiency, if you have leg swelling, you should be evaluated and get that treated. If you're obese, these semaglutide and similar drugs are very, very effective. We use a pattern to really cut down the cost of that, where we put it in a stepwise fashion to get people's weight down. We talk about that in another podcast. And then, do the advanced screening, CINT, which is carotid intermediate thickness test that checks your cardiac age. So basically it gives you age of your cardiovascular system. And if you're 50 and your heart age is 60, you got a problem. If you're 50 and your heart age is 50, you probably want to address it, because 1 out of 3 people are going to die of heart attack. So you have a good odds of dying of a heart attack, although it's not impending. It's not coming right away. It might be 20 years out. But if you're 50 years old and your heart looks like it's 60 years old, well, probably in the next 10 years, something's going to happen. We got to address that. Neurocognitive age, measure your brain. Okay, this is an MRI, full body MRI, and the liquid biopsy. And liquid biopsy is not that good yet. It will be good in the future. This is step 1. So the early adopters are going to do this. They're going to be okay spending $900 for a test that's not perfect, but it will get better. And then the last step is to reverse the age, which is senolytics, GERO inhibitors, thymus regeneration, reversal of epigenetic clock. And there's other things inside that package as well. Some people are doing plasmapheresis. That looks very promising. So just in brief, a friend of mine, David Hasse at the Maxwell Clinic in Tennessee, is who I refer to. He does plasmapheresis. And they found that there was a study where they took an old mouse and a young mouse. They were genetically cloned. It was the same mouse. There's 2 different beings. And they, let the mouse get to about, I guess probably 2 years old or so. And then they birthed the baby, and they did parabiosis, where they sewed them together, put their cardiovascular systems together, and the young mouse became old mouse became young. This led to people giving themselves young blood, a young plasma, where they would take the old plasma out of themselves and throw it away and inject themselves with young plasma. That procedure has been banned. But they found that taking the old plasma out and throwing it away seems to give some brain reversal and age reversal. And what is it? Is it the young plasma that was so beneficial, or was it the toxins in the old plasma? Well, it appears to be the toxins in the old plasma, particularly for neurocognitive decline. There's a large study called the AMBAR trial, AMBAR trial for Alzheimer's. And they took people that had early Alzheimer's or early to moderate Alzheimer's, and they did plasma exchange. I don't remember the frequency. I think it was a couple times a week for a couple months, and then once a month, and then they stopped. And what they found was they basically take the plasma out and throw it away and give them albumin and saline back. And they were getting these tau and amyloid, these plaques out of their blood system, which would create a gradient between the blood and the brain, theoretically, and pull those same plaques out of the brain that cause Alzheimer's. So your body doesn't seem to be able to get rid of these. In fact, you can do blood tests now, which weren't able to do a few years ago, to see if you have this stuff in your body, you have a significant load of these tau and amyloid proteins in your body that lead to Alzheimer's. But not necessarily lead to Alzheimer's. They're causative of Alzheimer's. They're in the brain. in the hippocampus. And if it's in your blood, that means you don't have a good gradient between your blood and your brain. You want to have nothing in your blood and some in your brain. It kind of extracts it. It's like a dialysis system. So they did this AMBAR trial, and they found these patients were getting meaningful improvement, particularly when they were doing the twice a week portion of the trial. Well, that was not a big enough study to lead to FDA to approve it, but I think you'll see this happening more often. However, people are doing this and they're seeing their epigenetic age go backwards a little bit. They might do it multiple times, and it does seem to reverse brain age. So that's promising. Hyperbaric oxygen has been tried. I'm not so sure about that yet. I haven't read any very good studies on it. And there's numerous other therapies that are under investigation right now for extending life. And there'll be drugs that are copying the already FDA-approved inexpensive drugs right now, such as rapamycin and dasatinib, because the drug company really can't make money on those drugs. They're out of patent. But if you make one that's a lookalike, then they would, prove that extends age. That would be potentially a multi-billion or multi-trillion-dollar drug. This is probably going to be the biggest industry in history once we figure out how to extend age, where you see people having lower birth rates. Well, if we could be healthy and fully in the workforce at 80 years old and feel like a 50-year-old when we don't have to worry about the population decline so much. So that's coming. And stay tuned. We'll be talking about different aspects of this as time goes on. Thank you very much.